need to win. Fantastic.
Good afternoon, everyone. Are we muted? Unmuted? Good. Thank you. I am Dr. Jean Joseph. I serve as chair of the Department of Urology. It's a great pleasure to have you all here this afternoon. And there are some faces I know, some I've worked with, and it's great to see you. Reminding me of a colleague, a physician who also was chair of another department I saw recently. Uh, he was traveling from out of the country and had significant difficulty from an obstructing prostate and had to make a stop. Finally made it home, so we're finally seeing him and has ongoing difficulty passing his urine. And this afternoon, I introduced him to Dr. Quarrier. Long story short, this is a gentleman who is a, a premier scientist expressing his frustration over dealing with emptying his bladder, things we take for granted. You know, as we get older, I often hear patients telling me, it's not like it was 25 years ago. I'm like, what is these days? So things change, and we in medicine are certainly there to help address those changes. Of course, some we have frustration when we can't deal with them, but a lot of things we can do for many things. And enlarged prostate is one of those conditions for which there are a lot of options. And a person with a large prostate, we have to go through the motion to make sure they understand it's not a cancer most of the time. That's the most common condition people face as they get older. And there was a time when the most common surgeries we would do were for enlarged prostate and for cataracts. So we still do a fair bit of enlarged prostate operations. And today we're going to give you some detail on the advancements that we've made in the field. We at the U of R are very focused on advancing the technology, advancing what we do to better care for our patients. And we've explored a number of treatment options. And this, we're going to hear about one this afternoon that is one of the best ones. And our team has spent a lot of time to develop expertise that is under the guidance of Dr. Quarrier, who is a member of our Endourology team. He leads, is from a Stone Center. He is a member of the Stone team, but this is an area where he has been building expertise in the region, where he's done hundreds of these procedures. So he cannot do it this afternoon, but he can tell you all about it. And this is a part of our mission to educate our community, part of our efforts toward engaging our team members in the community. Because our goal, as we've shared before with our folks from us who are here today, it's really to partner with you to share information so that you are well informed as you make decisions for your health care. And as my colleague physician experience, it happens to all of us. But we have to tackle it as a community and share the information, the latest knowledge, because what's reassuring is knowing that there are options, which is what Dr. Kaur will discuss this afternoon. So once again, welcome. I hope you enjoy the evening and make sure you get some drinks back there as well. So Dr. Kaur, good to see you.
Some housekeeping things before we begin. There is food and refreshments back there. Feel free to get up. And importantly, since this is a conversation about urination, this is urology. There's a bathroom right outside that door. You need to be aware of where those things are ahead of time, often when you're suffering from BPH. Um, we're going to take a step back, kind of go through the history of BPH, where we were previously, what the devices looked like, whether they're medical devices or torture devices. I'll let you decide. And then we'll step into modern times, go over a few of the options that we offer here. There's some wonderful options that we have. We'll go into all of them. And then we'll open up to some questions, and I'm happy to go over some things. Dr. Joseph said something important um, that initially we have to find out if it's really the prostate causing the issue. Is it prostate cancer? Along that lines, there are a whole bunch of other issues that can influence our urination. One of which is prostate cancer. Along the way in your treatment, we've certainly got to rule that out. We may come across it even if we think we've ruled it out. But other things also need to be looked at, namely diabetes. So, diabetes can certainly influence your urination. Putting out too much sugar in your urine pulls fluid into the urination, and you can start dumping additional urination. Can keep you up at night. Other things that may contribute to your urinary symptoms besides an enlarged prostate are things like sleep apnea. So although we're going to talk specifically about BPH, I don't want to say just because you're having urinary symptoms that it is BPH. That's something you've got to go through with your doctor, rule out these other causes because it may not be the prostate. It also may not be BPH, and still the prostate, it could be prostate cancer. So we've got to go through the process to figure these things out before we jump into saying that it is BPH. So when we talk about successful treatment, what is our goal? And every patient, this is one of the most critical questions for a patient. I try to ask it of every patient before we decide what treatment, because some patients, it's not what this displays. It's not, I want to be able to, have a fire hose with high volume voids. That's not their goal. Some patients, it's, I want an extra hour of sleep at night. I want to not to feel like I have to rush to the bathroom. So it may be urgency, it may be that frequency, it may be the night emptying. But what do we have to look at in the office from our successes? It's a patient who's able to store a large volume. So this shows that they were able to store 400 cc's and empty relatively quickly. In 20 seconds, they were able to empty that entire volume that they were able to store. So there's plenty of patients that present with some of these symptoms. Sometimes it's other symptoms. Sometimes it's I'm leaking. So I've got urgency. The urgency doesn't bother me, but when I start leaking and I need to wear a pad, or I have embarrassment because I go through a pad, that may be the primary objective. And we've got to address that. And there's many different options based on really what the primary objective is. One of the severe cases, of course, is a patient who presents with a catheter. You may have experienced the inability to void completely and need to have your bladder drained with a catheter. That's certainly an easier target for us getting the catheter out. That doesn't mean some of these other things aren't important. And we'll go into those in detail as we go through. So this is the kind of the outline. One of the important things before we get to the surgery is really going through what happens to the bladder, what happens to the enlarging prostate in this whole prostate. That takes years. BPH is not a condition that just presented. Often by the time I see a patient in the office, they've been suffering for years, may not even know that they've been suffering, but waking up once a night goes to 2, goes to 3, very slowly. And pretty quickly, it's 5 times a night that you're waking up. We'll talk about the standard medical therapy. We'll talk about the options that we currently use, when those are good treatment options, when those are bad treatment options, and then we'll go into surgical treatments, some that we consider minimally invasive. The MIST treatments, minimally invasive surgical treatments, love the acronym. It also implies that you're emptying, so it's even better. And then we'll talk about the transurethral resection of the prostate, and we'll talk about laser enucleation of the prostate that I do. Now, this is not a new condition, as I said. If you look back through surgical textbooks, some of the first surgeries ever performed were for enlarged prostates or their concomitant conditions like bladder stones. Will not cut for stone. That's referencing a bladder stone caused by BPH, an obstructive prostate. And some of the brightest minds have really gone after this and tried to solve this problem. Benjamin Franklin actually invented a silver coiled catheter to solve some of the problems that go along with catheters, to get a little better dwell time so you don't have to get your catheter changed every 4 weeks, which is still the modern practice. We don't have a better option, even though Benjamin Franklin tried to do it. Also, I can't imagine the cost of that silver coiled catheter. I think insurance companies would probably balk at giving you that much silver. Dr. Foley, inventor of the Foley catheter, also did a lot of the pioneering of intracardiac monitoring with a similar philosophy of this balloon that you float. It's also prevalent. It's not just historical with bright minds. I love the practicality that arose very early on. Now we see these golf bags that have fake clubs in it that are urinals. But back in the day, we had walking canes that had catheters in them. So this is clearly a prevalent problem. Clearly, brilliant minds have tried to tackle it. And clearly, there's some degree of associated stigma with it, where you have to hide your catheter in a walking cane. And I'm here to kind of dispel some of those because it is an incredibly prevalent condition. The prostate just continues to grow as we get older. So this is not something that you did anything wrong for. You didn't cause this. The prostate just grows. The bigger it grows, the more it obstructs. Now, when we started, we used horribly grotesque equipment. If you think this right here, shockingly, this was used to look in the urethra. So they put these jaws to open up the urethra and see inside. Luckily, we're a little bit more advanced. And actually, by 70 years later, from 1805 to 1877, we've really moved to a device that is very similar. My current residents probably would work their way around this scope, with one exception. This light at the end got actually very, very hot. And would sear the bladder. One of the important contributions of Rochester, actually, to urology and surgery at large actually happened around this light bulb at the end. Rochester and American Surgical Inc., founded here in Rochester, designed the bulb for this that wasn't causing injury in patients. You could operate for significantly longer. And it was used not just in urology, but any endoscopic procedure. So there's a lot actually that happened in Rochester. There's great history here. That's to look inside the bladder. Well, how did we address large prostates back then? Even though those scopes gave some inclination of what was going on in there, they didn't really allow us access to do procedures. So the first procedures to treat the prostate that didn't involve large open surgeries were blind. Young's punch, and Young is one of the pioneers of urology in the world, but pretty grotesque if you think about it. This is a blind device stuck in the bladder that just takes bites blindly into the prostate. You can imagine the amount of bleeding that occurred after that. There's no coagulation. There's no knowledge of what you're really taking a bite of. But pretty quickly, we realized something needs to be done. And we progressed and came up with resectoscopes that allow us not just to look into the patient, but actually start taking swipes and coring out the center channel of the prostate. So by the 1920s, we really had a device that I could use today in the operating room and no one would bat an eye. I'd like to talk for a little bit about the changes that occur as we age and really what happens to your entire system as your prostate grows. If we can switch over. All right. So forgive my artwork. If we think of the urethra with a prostate between it and the bladder, the prostate is a donut on its side, with the center of that donut, the donut hole, being what we urinate out. So urine goes this way. But what happens when the prostate enlarges, this channel gets closed off. So it applies pressure into the channel. That donut hole that went from wide open now is obstructed. So urine ends up turning around and pressure builds up in the bladder. The bladder is a muscle that we don't control directly. It senses the pressure and gets stronger by itself. It sends muscle fibers all along the bladder wall, crisscrossing. If you've ever had a cystoscopy, it can look like webbing crossing the bladder. That's called trabeculation in medical speech. But it's really just muscle fibers and a buildup of muscle fibers, all in order to empty the bladder. This happens without you knowing, not by choice. And it's those muscle fibers that cause severe urgency. Because when you have a stimulus, be it a molecule of caffeine or spicy food or just stretch from an enlarging bladder, that stimulus spreads along the muscle fibers and you get contraction of the entire bladder. What you're experiencing with those high pressures is nothing like anyone else. unless they're also suffering from BPH. It's significantly higher than anyone without a prostate. So you should be first in the line to get to the bathroom when you get home. And don't let anyone butt in front. But it also has other ramifications. Well, what are those? Unfortunately, the ureters, which are the tubes that connect up to the kidneys, also connect up here. That pressure can be transmitted up to the kidneys as well. And that's one of the things we really want to prevent. Pressure in the kidneys causes kidney decline. We definitely don't want to go on to dialysis. That's a very bad thing. In case you know anyone on dialysis, it's not a productive life. I'd certainly rather have a catheter or surgery for BPH before needing dialysis. There's other unfortunate things that happen from the enlarging prostate in this picture that we can demonstrate. There's this muscle out here. This is called the sphincter muscle. This is what allows us control to block off the flow of urine. If you've ever been urinating and tried to hold your urine in midstream, that's the muscle you're closing off. That muscle builds from just ambient pressure. It feels the pressure of the urine on it, and it gets stronger. Unfortunately, when the prostate's enlarging, as it is in this picture, the daily pressure right here is actually very low. And it's only in high spurts, 5 seconds, 10 seconds a day that you get this high pressure as the bladder contracts and you're emptying when something gets by the prostate. That is not enough to cause that muscle to get strong. So you've got a weak sphincter here as well. That's another reason during urgency and urge episodes, you may leak. You may not make it to the bathroom because you've got this combination of a really strong bladder and a really weak sphincter. Now, if we take it one step further, what happens when this has been going on for years? There's a couple additional things that can happen. The first is you can get outpouchings of the bladder through the muscle wall of the bladder. That's called a bladder diverticulum. It also happens in the bowel. You may have heard of diverticulitis. Generally, that's referring to the colon and diverticulum of the colon. Same thing happens in the bladder. The problem with that is there's no muscle around that anymore. So you can't generate pressure in here in order to empty that. So urine's going to sit there. You're more prone for infection because urine's sitting there and not emptying. You're prone for bladder stone formation. And we end up with a reservoir that your bladder just fills and never empties. Other things that can happen if you're not getting that release valve into these diverticulum is the bladder can fibrose. So smooth muscle, like the bladder, is different than the skeletal muscle of our arms, that we want to be strong in the arms. Being strong in the bladder is a bad thing, not just because of the pressures that can go up to the kidney, but the pressure over a long time, if the bladder muscle's not contracting, it ends up turning into this fibrotic tissue that is unable now to contract. So we end up with the end result being what's called an atonic bladder, or a bladder that doesn't work. All of this happens over a long period of time, often without us knowing. So you may present to your doctor somewhere on that spectrum, and it could already be with bladder diverticulum. It could be with a bladder that doesn't contract. It could be with bladder stones. Where you present is not always that clear. Why you present to a urologist, hopefully you've had them involved with your care already, so that they know and have some idea where you are on that spectrum, because we don't want to get to the point where we have a bladder that doesn't function, because ultimately then, even if we intervene and do something for the prostate, you still may not empty. Okay. We'll come back to this picture when we talk about procedures in a little bit. It's already a little too busy. We'll step back and clear it up and then talk about some of the procedures. But before we do, the most common scenario is actually a patient that comes to our office having already tried a few medical treatments. This is changing, though. There is a push more recently to stop the progression of this bladder deterioration that I've spoken about. That's only possible if we intervene surgically most times, with a few exceptions, and we'll talk about. But some of these medications only address symptoms rather than stopping the progression, and we'll get to that. Alpha blockers, the most common medication given for BPH. Why? They're very well tolerated, and they give an immediate feedback. So alpha blockers relax the smooth muscle that goes throughout the prostate, not the bladder, the prostate. This allows that channel to be a little less tight. So when you empty with more force. You may not be able to empty without them, and then on them, you get urine out. But they don't do anything for the prostate in terms of continued growth. So your prostate's going to continue to grow. I do think there is a benefit to the bladder muscle, though, with them, because the bladder muscle isn't as contracting with as much force. I do think they prolong the progression to an end stage bladder, because you don't need to generate the same force with the bladder to empty. Flomax is the most common medication in terms of alpha blockers. The one side effect that I want to make sure everyone's aware of, if you're on that and you get lightheaded when you stand up, that's what's called orthostatic hypotension. It can occur with this medication. If it's too much for you, you just stop it. It's not long-standing. It's quick on, quick off. Your urination, of course, will quickly get worse, but often you don't want to risk blacking out when you stand up. 5-alpha reductase inhibitors, the other very commonly used medication. This is a medication that stops the conversion of testosterone to a more aggressive form of testosterone, more active on the prostate. It has very little activity elsewhere other than hair follicles, so it is also used for hair growth. But there's some things to remember with this medication. The side effect profile is not as benign. So you can develop things that are long-standing and don't go away. You can get decreased libido or sex drive. It can also cause erectile dysfunction in some cases. It can cause breast enlargement or breast tenderness. What scares me is in a very small percent of patients, very small, I don't want to alarm you, it can increase the risk of depression. So that is something where a patient who's on antidepressants, I don't feel like this is probably the drug for or medication for you. But it works very well in conjunction with the alpha blockers, and it's the only medication on here that actually shrinks the prostate. Not significantly, though. It shrinks it about 30%. So if you have a very large prostate or some anatomic variation of your prostate, and I say that because there are different prostate configurations that may not be improved with this medication. And that's where a cystoscopy or looking in with a camera really comes into play. You may have heard of a median lobe. We don't need to go into it in detail, but that may not be affected by this medication. Okay. There's another medication that's being used more frequently for BPH as its price has come down dramatically. That's Cialis. Cialis in its daily form, you may have heard of it for erectile dysfunction. Wonderful side effect of improving erections. But in its daily form, it's very good at helping the smooth muscle relax in the prostate. So you can get a little more benefit from the relaxation, similar to alpha blockers. Side effects of Cialis. First of all, you can't be on nitroglycerin for your heart. Definitely can't be on that. It will also cause some lightheadedness or orthostatic hypotension. Combination of Cialis and alpha blockers can be used, but I'm very skeptical when patients say that they're blacking out. That's not a good combination to have them on if there's any degree of orthostatic hypotension. Anticholinergic medications. These are medications, and there's an additional one that's not quite an anticholinergic called mirabegron, that target the bladder muscle. I don't like these medications. They're treating symptoms without addressing the progression. So these medications relax the bladder. They make your bladder not contract as strong, but they do nothing to reduce the force needed to empty. They do nothing to reduce the size of the prostate. Ultimately, if you're on these medications, that's a sign to me you need a surgical treatment for your prostate because you're progressing to the point that you're already having what I consider end stage effects on the bladder. So these are medications that can be used for short periods to address that urgency, but ultimately I want to get these off as soon as I can because I'm afraid of the progression of the bladder. Additionally, these are very dirty medications. They cause a lot of side effects that I really don't like, namely dementia. So this is something where I get really nervous on. All right, that's all we have from a medical therapy standpoint. All these years, all these great devices that we're going to talk about, and we really only have these four primary groups. And as I've told you, they're not great drugs. And I don't know any in the near future that we're going to release either. No one's has approached us to do any trials on any new medications in any of these classes. So let's touch on surgical treatment. surgical treatment it's really important to go back to that conversation about the goal. What is the goal of therapy? Is the goal to get rid of a catheter? Is it to maintain sexual function? And there's kind of two classes for that we'll talk about. Is it to never have another surgery? Is it to get off medication? Is it to get an extra, maybe to go from 4 to 3 times waking up at night? That's very important because there's a huge range of surgical therapies. Critically, though, we need to know the size of your prostate in order to say what treatments are available for you, because not every treatment is available for every prostate. There are some that are, but most of the minimally invasive, the mists, the ones that may preserve sexual function like ejaculatory function or erectile dysfunction, are only available for smaller prostates. I want to be clear about ejaculatory function and erectile dysfunction, because erectile dysfunction is really only affected in the traditional transurethral resection of the prostate, and it's only affected a little bit. So for the most part, most people that come to me and say, I want to preserve my sexual function, and I start asking them, okay, what do you mean by sexual function? Do you want to be able to get an erection? Do you want to be able to have an orgasm? They answer yes to those. Pretty much every treatment is fine. Alternatively, if they say the most important thing to me is forward ejaculate, well, that changes the conversation, because then you're only have as an option a couple treatments. For the most part, as long as you know it's not a health risk to lose your forward ejaculate, I think you're in a good spot. Okay. There are some indications where I will skip medications and go right to surgery. Those are times I have a suspicion of an end-stage bladder, like already has acute urinary retention and needing a catheter, or having recurrent urinary tract infections. We talked about bladder stones. We talked about the effect on the kidney. These are all times that I may jump straight to surgery. All right. One of the newer treatments we have is a procedure that applies a stent for about 5 to 7 days. So you have nothing in your body long term. We don't remove any tissue. It expands, pushing tissue out, and your body conforms to that shape. And then we remove the stent. That's called iTind. These are implantable stents that get removed, so they're temporary. There's a whole bunch of them. I think 7 now have been approved. They all do the same thing. You deploy them.
The iTind is a straightforward, minimally invasive procedure for the treatment of benign prostatic hyperplasia by using a temporary
Audio. Yeah. So you implant them in the prostate. The benefits being you can still get MRIs. They don't change what a MRI for prostate cancer evaluation does. Like some of the others, UroLift does actually affect the interpretation of MRIs for prostate cancer. And it's immediately removed, doesn't affect the future in terms of treatments. The main reason you would do something like this is if you want to preserve forward ejaculate. That is the benefit of this device. It's for very small prostates. In my algorithms, I'm thinking 50 cc's or less. This is a device I would use. But it does preserve that ejaculatory function. Another similar device, same size prostates, the smaller prostates, is called Urolift. The main difference between these two is you remove the device in the iTind or the temporary implantable stents. In this procedure, these staples that you place to compress the tissue stay in place. If there's a concern for prostate cancer, say you're on active surveillance for prostate cancer, they don't want to do a surgery, but you're going to be getting MRIs moving forward, I would not recommend this device. It has the same benefits in terms of preserved sexual function, that ejaculatory function, and it does not inhibit future treatments. So I can do any of the other treatments on a prostate that has had these devices. Why do we know that? Well, the secret about mists is they need retreatment frequently. These aren't the durable procedures. They aren't the procedures that last forever. If I'm seeing you've got renal compromise or an end-stage bladder, I'm not leading you towards miss. I'm trying to understand why ejaculatory function for you trumps kidney function, trumps bladder function. Another procedure that doesn't require implants is the Resume. This is a device that applies thermal energy, steam, to heat and kill the prostate, and your body resorbs it. So I'm not removing any tissue, but it does result in a smaller prostate after, as that steam kills the tissue and your body resorbs it. I like this procedure because you're not leaving implants. However, in my mind, the major side effect of this procedure is the first month can be challenging. The steam initially causes inflammation. You can end up with a catheter for 2 to 6 weeks after these procedures because of the inflammation blocking things off before you get that relief. The traditional treatment has always been TURP, one of the most common procedures we've ever, we used to do, only recently supplanted by another procedure we'll talk about. It's actually a very good procedure. This is where we go in through the urethra and we scrape out from the inside, almost like a roto-rooter, a channel. I like it because, one, I get pathology. The majority of patients with larger prostates have an elevated PSA. We don't know if cancer's hiding in there. The other procedures, I didn't remove any tissue. This, I send off all the tissue I get for evaluation for prostate cancer. And we do find prostate cancer. In our data, we looked at this year, 4% of pathology from this procedure and 2 other procedures comes back positive for clinically significant prostate cancer. My question is always, what about the procedures we didn't remove tissue on? That's prostate cancer that we don't know about. We don't have that diagnosis. The issues with this procedure are few, but you do get a significant amount of bleeding because you are scraping from the inside through many webs and meshes of vessels. The layers that we go through in this procedure aren't the surgical plane. We're not peeling an orange. We are just taking swipes from the inside out. And it's almost think of the prostate as a sponge of kind of vessels. They just ooze because they're not defined vessels in the layers that we're going through, in this center layers. So there is a higher transfusion rate. Additionally, we don't do as good a job as 20 years ago, 40 years ago at this procedure. I don't know why, but it is clear from analyzing the data, the retreatment rates with TURP have gone way up. I think they used to be a lot more aggressive on this. You remove a lot more tissue, leading to a procedure that has a longer duration than we currently do. Modern TURPs just don't remove the same amount of tissue as they used to. Aquablation. This is really a missed procedure. I think there are very few times, except for the very small prostates, the 40s and 50s, where the other missed procedures I talked about are better than this procedure. What this procedure does, and if we can switch over to my screen, what this procedure does is it uses ultrasound guided ablation. So we take a water jet, robotically assign where it's going to go, and it destroys the tissue. Some amazing things with this. The first of all, if you care about forward ejaculation and you have a prostate that's greater than 50 cc's, this is the procedure for you because it preserves that even in those intermediate prostate sizes. There are some major drawbacks. First of all, bleeding is higher than even TURP. It's higher than the alternative, which I'll talk about in a second, HOLIP. And you don't address all the tissue. The anterior portion of the prostate, think of it half an orange, is not touched. Because this procedure is not quite precise enough, I think 3 generations from now, it will be. But because it's not precise enough, we never have it go on the anterior part of the prostate, which is the top of the prostate, because there's a lot of vessels there. And from a liability standpoint, I don't think the company is comfortable assigning tissue removal anteriorly. So we do not do that. There's a lot of patients, and you should take a look. If you've had an MRI, you should take a look at, we can switch back. You should take a look at the degree of prostate tissue that is on the top versus the bottom. You say, how much of my prostate is anterior tissue? Because that will not be touched with aquablation. That in turn means retreatment rates like the other missed procedures. So at 5 years, it's around 5 to 7% need another treatment. But I love the forward ejaculate. This is the procedure. If someone really needs that forward ejaculate, which no judgment, I don't think is necessary for sexual function, that I would steer someone to. The other problem with this is you don't get tissue for pathology. Some urologists swear we get tissue. And what that means is after the water jet ablation, we take swipes because of the bleeding. We need to clear up that debris and then cauterize underneath it. That debris is really no good for the pathologist, but it does get sent. But it's really not good for analyzing. So you lose the ability to evaluate for cancer. All right, the procedure that I do primarily is laser enucleation of the prostate. This works with all size prostates from 30 to 450 is the largest that I've done. And it's definitive. 2% lifetime retreatment rate because it peels the orange. The reason you don't get bleeding, and our urologic society says that you can do this on patients on anticoagulation, this is the preferred procedure, is because we're in a totally different plane. We are in a plane where it's discrete vessels rather than a sponge full of blood cells. We send off to pathology all the tissue. You're catheter free, drug free, with some major exceptions. And everyone who undergoes this procedure needs to know. Firstly, because of that imbalance, remember the strong bladder, the weak sphincter, we completely treat the obstruction unlike any other procedure. It's full enucleation, removes more tissue than anything else. You've got full exposure of that sphincter to the high pressures of the bladder. Initially, you will leak. It takes on average about 6 weeks till you regain control. Doing exercises, Kegel exercises, strengthening that pelvic floor. At 3 months, 10% are still leaking. That's a long time. The younger you are, the better you do. At a year, that number's down to about 2 or 3% as that bladder passively relaxes. That's the key in all of this. It's that imbalance. That's how I know it's bladder related, because that's the time frame that the bladder gets to the point where it's not having this urgency, this high pressure, things like that. This is an example of when I'm saying peeling the orange, there really is a plane there that we're using coming through with discrete vessels. I'm not just cutting into this. I'm using your body's plane to define where I'm going. So you ask me, oh, can I do more or less? No, it's where your body separates, just like you can't peel an orange more or less. If we can go to the next slide. Can you, thank you. That's really all those are the important things that we've talked about. To just give you a summary of where we are, we actually started this program doing laser enucleation back at the end of 2020. At this point, we've done over 700 procedures, and we are the highest volume, higher than anyone in New York City. I think you have to go to Boston probably to get someone who's close to our numbers. And that's really all I have. I'd really like to open it up for questions.
When you spoke about when you did the TERP and you got tissue and you said you were finding more cancer cells,
Mm-hmm.
are these people that would have the high PSA to begin with, or if that was a surprise because the PSA was low?
Always a surprise, because even if their PSA is elevated, we've done biopsies, we've done MRIs. So these are patients that we've already said your risk is low. But remember, a biopsy is 1,000th of the tissue. You're sticking these little tiny needles in an orange 12 times and expecting to say that there's no cancer in this orange. We can't say that. We can just say the biopsy is negative. So that 4% that we found is across all procedures in patients who've had previous MRIs, previous biopsies, unexpected clinically significant prostate cancer. Yes.
Reading recently about prostate artery embolization.
Mhm. Of course. I utilize it. I do send patients for prostate artery embolization in very specific instances. If a patient is too sick to undergo surgery, I will send them for prostate artery embolization as a last ditch effort. Personally, I don't think you get the effect that you need to get rid of a catheter, to get rid of medication. I also don't like the idea of going to a proceduralist, the interventional radiologist, that doesn't follow you. So in my mind, it doesn't give you the reduction in prostate volume required to get a good durable effect. I also want to say a prostate artery embolization is equivalent to 200 CT scans in radiation. So it's not a benign procedure. It takes about 5.5 hours at strong is how long it takes. And it's about the equivalent radiation of 200 CT scans. Yeah.
We have a couple questions online, Dr. Quarrier. The first one is, what is your opinion on PAE?
I think that was
Already answered.
just addressed. Yeah.
Perfect. Thank you. The other one, this might have been addressed also. Do you always do MRIs before biopsy these days? What are the percentage of cancer that is missed from MRIs?
Excellent. So I don't always do an MRI before a biopsy. It depends on if their PSA is elevated. If I know the size of the prostate, there are times where I will go straight to a biopsy. For example, if I feel a nodule on a digital rectal exam, I'll often go straight to a biopsy, but they are becoming more and more prevalent. There is definitely cancer missed. We know that from MRIs. What I can tell you, because I do a procedure that is enucleative, meaning we send off tissue to pathology, and it doesn't inhibit treatment options after, I am very comfortable doing this procedure on someone even that has prostate cancer. So I will often do this procedure on a patient who's on active surveillance, not to treat the prostate cancer, to treat their urinary symptoms with the knowledge that we can treat their cancer after if we need to with radiation or any other surgical intervention. We'll actually be asked by radiation oncology to reduce the size of a prostate before radiation for prostate cancer because they have to give less radiation dose to a smaller prostate. So I think the utility of getting additional tissue for diagnosis as well as treating symptoms that will persist even if you have external beam radiation really don't limit. I don't get limited by finding cancer. I think these are very grateful patients because their symptoms are essentially cured off medication. There are times though that we will still have to treat prostate cancer if we find it.
Last question online is, are there any ED issues with the LEP procedure?
No, it does not affect erectile dysfunction, good or bad. I do have patients who expect to have increased erection quality because their prostate is now a normal size. That's not the way it works. Once your erections are gone, for the most part, they're gone. So it's not a positive or negative on erection quality.
We had another one just pop up that says, is general anesthesia used for these surgical procedures versus localized?
Some it is. It really depends on the surgery. So some of the mist we do actually in clinic. Resume we do in clinic. Hopefully in the near future we'll be able to do the implantable prostatic stents and removal in clinic. There is a reimbursement issue with CMS with that right now, where we will not get paid for them if we do it in clinic. And UroLift, in rare cases, you can do it in the clinic. Everything else is done under general anesthesia, with some being able to be done under spinal if they need it. But that's really few and far between with the spinal.
I'm so sorry. If you had the LEP and you're saying that there's still a problem with leakage afterwards, if you then were found to have prostate cancer, needed radiation, given that radiation will halt any.
Yes.
Good.
So we work very closely with our radiation oncologists on determining what is the appropriate time to start radiation. In general, it does take about 3 months to fully heal before I'll have the radiation oncologist give radiation. But sometimes little more nuanced. Sometimes I'll actually have to do a cystoscopy to assess the healing after, before allowing radiation. Yeah. Yes.
So I'm pretty new to this, but what I'm recognizing is that it seems like various doctors have different favorite procedures. There's a number of urology doctors at U of R. If I go to Dr. A, is he going to be aware of all of the 7, 10 different procedures and pick the best one for me? Or do I need to shop around and talk to all of you guys?
So we are all aware. We actually communicate frequently. I refer patients all the time. We went through in detail 5 procedures today. I do not do all of them. I do 2 of them. But that doesn't mean I don't send patients. And as I said, aquablation, there are times and patients that I will send directly over. What I can say is you will get a procedure that works for you. Often there's multiple that are excellent at doing and achieving the same goals. So even though a doctor says this one is the one for you, and someone else may say this other one is the one for you, it's their judgment that they would be equivalent in terms of your outcomes. I'd always say you want to be served by a doctor who's comfortable in the procedure they're doing. So, for example, you don't want me to be doing your aquablation. It's not a procedure I do. I send patients frequently for that to a surgeon who's done them over and over and over, and it's what they do. So I think we have a very good balance of BPH surgeons here who each choose to specialize in certain procedures and refer out back and forth, all in the interest of getting you a surgeon who's very skilled at what they're doing and what you're getting. Yes.
Does a TURP inhibit getting a prostatectomy and find cancer?
So none of these procedures make it impossible to get a prostatectomy. However, they can make it a little more challenging. And they may make some of your risks different. For example, a prostatectomy on a very, very, very large gland is a very challenging procedure. And it may benefit to have it reduced in size. Conversely, there are procedures that may make it a little more challenging. We do not do any procedures that make it impossible to treat prostate cancer because we find it so often that would be a major challenge. So you can do radiation. We do it before, these procedures specifically before sometimes radiation. And we do prostatectomies after all of these. Yeah.
Doesn't the radiation make it more difficult to do a prostatectomy? If you,
Yes. Yes. Yeah. Usually we do it after the radiation after. Yeah.
Just want to add, I hope you enjoyed this wonderful talk by my colleague, Dr. Quarrier. Just want to echo what you just said. We all have different expertise, and we want to know what's on the horizon, what's better for the patient. Not one size fits all. That's the key to understand here. And in this environment, all of us, not just here, but in Rochester, to work as a community. But here in this building, we are definitely a community from the standpoint that he's practicing a couple always away from me. I can go reach, hey, what do you think of this? Can you take care of this patient? So to answer your question, what's best for is what we are patient-centered care, or we want to deliver patient-centered care. That's the key to deliver the best results. So in fact, the spirit of building this office was to bring us together in a large group practice to work as a community. I want to take a second to give a recognition to the person who helped us build this office. Miss Fiona right there. She was chief ambulatory nursing officer some time ago. And she walked in here with a hard hat on and helped us build this enterprise. So you see what we made of this room, so I'm glad you're here to be part of this. Again, it's our effort to engage all of you in your health. The more you know, the better informed, the more you are engaged in the decision you're making about your health, and discussing with your physician. And frankly, I'm sure I'll speak for you, Scott, in saying that you want an informed patient who asks all the questions, and so you have the right dialogue and the best treatment decision.
Yeah.
With that, it's great to have you here. And those that are here online, thanks for joining us.
Yeah.
Again,
Thank you so much.
Guys are also nice, yeah. Get together. Don't like the limelight, but they are.